Hello friends, today I will be discussing the ENT questions of GT 180. Coming to question number 57, it says following tonsillectomy, one of the main sources of prolonged post-operative bleeding is from. The answer is A, that is the external palatine vein. Now the external palatine vein is also known as paratonsillar vein. Now we have to understand that this vein is present behind the capsule. It is present between the capsule and the superior constrictor muscle. The superior constrictor muscle is the muscle which is adjacent to the capsule of the tonsil. The capsule of the tonsil is formed by the pharyngobasilar fascia. This is also a MCQ. The capsule of the tonsil is formed by the pharyngobasilar fascia, and the most common source of prolonged postoperative bleeding is from the external palatine vein or the paratonsillar vein. There is other blood supply also, the arterial blood supply also, which can be remembered by the mnemonic FLAM. Now FLAM, F stands from the facial artery, L is the lingual artery, A is the ascending pharyngeal artery, and the M is the internal maxillary artery. Now these are the four arteries, these are the branches of the external carotid artery which supplies the tonsil. So the facial artery gives the tonsillar branch. This is the most common branch which can cause the bleeding. And then is the lingual artery. Lingual artery gives branches which are known as dorsal lingual branches, and ascending pharyngeal is also a blood supply of the tonsillar. It gives a branch which is known as tonsillar branch, and maxillary artery gives the descending palatine artery. So the venous supply is from the external palatine vein, whereas the arterial supply is by the external carotid artery branches, namely the FLAM, the facial, the lingual, the ascending pharyngeal, and the maxillary artery. So here the question number 57, answer is A, that is the external palatine vein. Now coming to the next question, it is an image based question. It says a 20-year-old woman presents with history of scanty ear discharge since childhood. While cleaning the ear today, she had bleeding and came to OPD, and on otoscopic examination was performed, and all are true about the condition shown except. Now you can see then that in this question it is a picture of the ear. You can see above the arrow part. The arrow part is showing the perforation, or it is showing a aticoantral disease. It is showing the aticoantral disease. So aticoantral disease is the we can also say it is a aticoantral disease or a cholesteatoma. Cholesteatoma, as we know, cholesteatoma is not a tumor, it is a misnomer. So cholesteatoma is the skin present in the middle ear. So out of the given question we have to tell which is false. So coming to question number option A, it is the aticoantral type of perforation. This is correct. Option B, it is a cholesteatoma, which is epidermal inclusion cyst containing cholesterol crystals. Now here I want to say that it does not contain the cholesterol crystals. The cholesterol crystals are present in the cholesterol granuloma, not in the cholesteatoma. Option number C is also correct. The cessation of discharge is an ominous sign, and option number D is also correct, that is the development of vertigo following labyrinthitis. Labyrinthitis is the complication of cholesteatoma. So question number 58, answer is B. It is the epidermal inclusion cyst, but it is not having the cholesterol crystals. Now coming to the next question, that is question number 59. A 25-year-old male complains of difficulty in hearing which has been worsening over the last 6 months with occasional tinnitus. So, here we are having a male who is having a gradual hearing loss over the period of 6 months with occasional tinnitus. Otoscopy shows normal TM. Pure tone audiogram shows, if we can see in pure tone audiogram that the bone conduction at 2 kilohertz it is dipping, but at 4 kilohertz it is coming back to the normal, whereas air conduction is not dipping at the 2K. So, this is a typical feature of Carotid notch, and from the diagnosis, from the history, what we can diagnose, it is a case of otosclerosis. So, question number 59, answer is A, that is otosclerosis. Now, Carotid notch, though it is not always present in otosclerosis, but it is diagnostic for otosclerosis. Had it been that there is a dip in bone conduction as well as in air conduction at 4 kilohertz, this is noise induced hearing loss. So, answer to the question number 59 is A. It is showing a Carotid notch which is diagnostic of otosclerosis. Coming to the other options is Meniere's disease. In Meniere's disease, we will have a vertigo component also, so that is ruled out. There will be no Carotid notch in Meniere's disease. Whereas in serous otitis media also there will be worsening in the ear, but there will be worsening in the hearing, but there will be no Carotid notch. And option number D is also ruled out because with earwax we will not have such kind of a hearing loss. Now, coming to question number 60, true about Baja. Baja is bone anchored hearing aid. So, it is useful in canal atresia and microtia, that is correct. It is useful in bilateral severe SNHL, this is wrong. Option number C, useful after surgery in neurofibromatosis type 2 for acoustic neuroma. Well, in neurofibromatosis type 2 for acoustic neuroma, we do not do Baja, we do what is known as the brainstem implant. It can bypass cochlea. The function of Baja is bone anchored hearing aid, so it directly stimulates the cochlea. So, it does not bypass cochlea. So, option number E is the only correct option in the given options. So, answer is question number 60, answer is A. Baja is bone anchored hearing aid. It is a type of hearing aid which stimulates directly the cochlea. It bypasses the external auditory canal and the middle ear. So, coming to indications of Baja, what will be the indications of Baja? Indications of Baja will be, think about conditions of the external auditory canal and the pinna. So, option indication 1 is when air conduction hearing aid cannot be used. Now, what are the options, what are the conditions in which air conduction hearing aid is cannot be used? When there is a canal atresia, that means the canal has not developed and there is no lumen in it. So, canal atresia, it can be congenital or it can be acquired and it is not amenable to treatment. Second, when we can't use the air conduction hearing aid is when a patient is having a CSOM and there is profuse discharge. So, when there is a chronic ear discharge. Third is when there is excessive feedback. Now, feedback occurs, suppose if we have done a modified radical mastectomy and there is a large external auditory canal. So, the sound will leak from the microphone to the speech processor and there will be excessive feedback. So, we cannot use air conduction hearing aid in such cavities, in such ear with large ear cavities and large external auditory canal. So, that is also one of the indication where we cannot use the air conduction hearing aid. Second is coming to the middle ear, when there is a conductive or mixed hearing loss. Now, the conditions where in the middle ear it will be present is, one is the otosclerosis and the other one is the tympanosclerosis. Though in otosclerosis we can do stapes bypass, we can do stapedotomy and we can put a piston, but if given an option, we have to give the option to the patient that we can also use Baja. Third is when there is a single sided hearing loss. If the patient is having a unilateral hearing loss, then also we can use the Baha. So, these are the three indication. First one is when the air conduction hearing aid cannot be used. Second is when the patient is having any disease in the middle ear, whether it is a conductive or a mixed hearing loss, then it can be used, or if the patient is having a single sided hearing loss. Now, in the option there is a thing which says it is patient is having a bilateral severe SNHL. Now, if there is a bilateral severe or profound hearing loss SNHL, we do not use Baha, we use what is known as cochlear implant. So, cochlear implant is used in such conditions, and as I have told you, if the patient has undergone bilateral acoustic neuroma excision following bilateral acoustic neuroma excision, we use a auditory brain stem implant, we do not use Baha. So, here the answer is the patient is having a canal atresia. So, answer is option A. Now, coming to the other question. Question number 61 says, Mr. Suresh presented with persistent hearing pain, persistent ear pain and discharge. There is retroorbital pain and modified radical mastectomy was done to him. Patient comes back with persistent discharge. What is your diagnosis? Now, here the question is giving us three hints that the Mr. Suresh is having a persistent ear discharge, patient is having retroorbital pain, and modified radical mastectomy was done on him. So, modified radical mastectomy was done for aticoantral disease for cholesteatoma ear. So, if the cholesteatoma ear mastectomy was done, so what are the first and foremost complication of cholesteatoma? It is Petrositis. So, if the infection travels to the petrous part of the mastoid temporal bone, the patient can have Petrositis. So, here the option 61 answer is C. Patient in Petrositis will have deep retroorbital pain, there will be a persistent ear discharge and there will be a diplopia. Diplopia is because of the involvement of the sixth nerve, whereas deep retroorbital pain is because of the involvement of the fifth nerve. So, this three components, it is also known as Grady-Nigo syndrome. Though sometimes all the components might not be present, but the patient will have the involvement of the fifth and sixth cranial nerve, and patient will have a persistent ear discharge, as in this case Mr. Suresh is having. So, diplopia is because of the involvement of the lateral rectus. Lateral rectus, as we all know, is supplied by the sixth cranial nerve. Deep retroorbital pain is because of the fifth cranial nerve, and patient will be having a ear discharge. So, this is in question is a typical of Petrositis. And how we treat Petrositis? The mainstay of the treatment is adequate drainage along with the antimicrobial therapy, depending upon what culture the what has come on the what microorganism has come on the culture, we give the antimicrobial therapy. So, answer is C, that is the patient is having a Petrositis, and in Petrositis we see Grady-Nigo syndrome. Now, coming to question number 62, which of the following is not a contraindication for bronchoscopy? So, answer over here is C. That is active bleeding. Now, bronchoscopy is the examination of the tracheobronchial tree. So, if we have to do a emergency, it can be emergency or it can be elective. So, if there is a emergency bronchoscopy, there is no contraindication. Like in this patient if the patient is having active bleeding, so there is no contraindication, and if the patient is undergoing a elective bronchoscopy, we can have certain contraindications which can be trismus, when the patient will be unable to open the mouth. Second is the aortic aneurysms. The patient will be having cervical spine disease, spondylosis or anything like that, and the patient is having a pulmonary hypertension, if the patient is having a cardiac failure. So, these are the some of the contraindication if there is a problem in the cervical spine, whether it is an inflammatory condition or it is a metastatic lesion, or if there is a aortic aneurysm, the patient is unable to open the mouth, as in the case of trismus, the patient is having a cardiac failure or a pulmonary hypertension. So, these are the contraindication for a elective bronchoscopy. There is no contraindication in case of a emergency bronchoscopy. Coming to question number 63, it is a image based question. Identify the pathology in the given image. Now, you can see this is a X-ray soft tissue neck, and if we carefully see just behind above the hyoid bone, we can see a thumb like lesion. So, this thumb like is the epiglottis, it is a swollen epiglottis, and it is also known as thumb sign in the radiology. So, the answer over here is acute epiglottitis. So, question number 63, answer is A. Here we have not been given any of the symptoms of the patient, we are just given the radiology, and in the radiology we can see that there is a swollen epiglottis, and this is also known as thumb sign. Now, acute epiglottitis, it can occur it can occur in all age groups, but most commonly in children it occurs in 2 to 6 years. It is caused by H influenza, but with the advent of the influenza vaccine, this organism is becoming rare. It can be caused by other organism like Streptococcus pneumoniae. How the patient will present to you? The patient will come with acute onset fever. There will be a inspiratory stridor. Now the inspiratory stridor is because anything above the vocal cord will give you an inspiratory stridor and below the vocal cord will give a expiratory stridor. So epiglottis is present in the supraglottic part, it is above the vocal cords, so it will patient will have a inspiratory stridor. Then there will be odynophagia, because when we swallow our whole supraglottic moves, and moreover the epiglottis, it comes back and shields the larynx so that the food does not enter the airway tract. So patient will be having a odynophagia because of the swollen epiglottis, and but the most sparking feature is the cry is normal in such kind of patients. So this is how a patient will present to you, and if depending upon the severity of the patient, we can give steroids to the patient, and we can give nebulization, or we can start the patient on the antimicrobial therapy. And if the airway is getting compromised, our first option will be to intubate the patient, but if the intubation fails, then we go for the emergency tracheostomy. But one word of caution in such patient, that if you are sitting in a OPD and the patient comes to you and you are suspecting acute epiglottitis, then you should not be seeing the patient with a tongue depressor, because it can precipitate a airway obstruction. So you should avoid that, and you should be relying more on the clinical features of the patient. So answer over here is A, that is acute epiglottitis. Now coming to the question 64, improvement in nasal patency by retracting the lateral part of the cheek. Improvement in the nasal patency by retracting the upper part, the lateral part of the cheek. This, the vestibular component, and testing the vestibular component of nose is, this is a Cottel's test. So answer is B. Question number 63, answer is B. Now Cottel's test is done, it is used in nasal obstruction due to abnormality of nasal valve. So if the patient is having nasal obstruction because of the nasal wall, and if we do Cottel's test, and if the patient is relieved of the nasal obstruction, that means this patient is fit for septoplasty. We must do a septoplasty in such kind of a patient, and he will be relieved of his obstruction. So this test is known as Cottel's test. Whereas if you see the other options, Eppler's maneuver is a maneuver, it is a particle repositioning maneuver, it is done in benign paroxysmal positional vertigo. There is no such thing of the in ENT of Schwartz maneuver, whereas the Hamlich maneuver is a maneuver which is done for the obstruction of the airway due to any foreign body. So answer over here is B, that is Cottel's test. Now question number 64, question number 65, it is an image based question. We have been asked to identify the given instrument, and this is a adenoid punch. Answer is B, that is the adenoid punch In this adenoid punch, we take a biopsy from the adenoid. It is also known as Meltzer adenoid punch. So, just remember the image, and this is a Meltzer adenoid punch. Now, coming to question number 66, it states Lyrace sign is seen in. Lyrace sign is seen in carotid body tumor. Question number 66, this is 65. Lyrace sign is seen in carotid body tumor. What happens is, if we do carotid body tumor is present at the bifurcation of the common carotid artery. This is the common carotid artery, and this is the internal carotid artery, and this one is the external carotid artery. So, chemodectoma, which is, it is also known as chemodectoma, carotid body tumor, it arises from the, arises from the chemoreceptors. The chemoreceptors are present at the bifurcation of the common carotid artery. So, in this the chemoreceptors are present in the carotid body, which is present at the bifurcation of the common carotid artery into the external carotid and the internal carotid. So, if the tumor arises here, it goes and splays the internal carotid as well as the external carotid artery. So, if we do a MR angio, if we do a MR angiography, if we do a MR angiography in this patient, we will see the splaying of the internal and external carotid artery. So, this splaying of internal as well as the external carotid artery on a MR angio, this is known as the Lyrace sign. It is not a clinical sign, it is a radiological sign. Now, something more about the carotid body tumor. It is seen in patients who are living in high altitude. It is seen in patient living in a high altitude. It is a very slow growing tumor. It presents as a painless and pulsatile swelling. So, a swelling which is present in the neck, which is painless and pulsatile, and it always have a bruit. If we use a stethoscope with the bell, if we see, there will be a bruit in such kind of lesions. The main peculiarity of this lesion, apart from being pulsatile, is that it cannot be moved, it cannot be moved vertically, it moves only side to side. So, this swelling moves side to side, that is, it moves horizontally, and it does not move vertically. So, that is one of the hallmark feature of this swelling. So, we have to diagnose this case clinically, and we do not have to do a FNAC or a biopsy. So, FNAC or biopsy is contraindicated. And if the patient is young, we have to do a what is known as surgery, that is the excision in young patient, whereas in elderly we can also use radiotherapy. But this is a patient, this is a tumor which is highly vascular, so that is why we should not do FNAC or biopsy. This is also one of the caution, and swelling moves horizontally and not vertically, this is also one of the question. As I said, it is seen in patients who are located in high altitude, and it is a very slowly growing tumor. You have to diagnose it clinically, and or MR angio we will see a Lyris sign. Lyris sign is playing of the internal as well as the external carotid artery.